Okay, let me repeat once again. Today I'll be talking about three tunnel syndromes in the upper limb, and then I'll be discussing some of the not very common, but yes, the entrapment neuropathies of the lower limb. In the upper limb, you must be very, very, very much thorough with your carpal tunnel syndrome, because this is the one syndrome which you will be seeing very often in your uh, your primary, as a primary care pain physician, you will be able to see this syndrome uh, very well. So you should be having a thorough knowledge. And what I have planned to do today is, like, I will be discussing the anatomy, and then we will be discussing about the syndrome. I'll be showing you the sono anatomy, and then we'll be talking about the intervention. And one by one, I'll be discussing so that we are not confused with all these three syndromes. So let's start with the carpal tunnel. Carpal tunnel, the easiest, these are the carpal bones. First of all, as what we have learned during our MBBS days, the mnemonic, she looks too pretty, try to catch her. So if this is my thumb, this is little finger, right? So you start from here. So the first S, she looks too pretty. So she looks too pretty, try to catch her. So this try to catch her is the distal row, and she looks too pretty is the proximal row. For a basic course, you need not remember all this. What you need to remember is only and only these four bones. And in order to make you people understand, I have just tried to make it very simple so that you do not forget the carpal tunnel ever in your life. Imagine that carpal tunnel, what exactly is this? So you have your carpal bones, they are like this. Their arrangement is like this. On the top, you have your flexor retinaculum. So now what this flexor retinaculum has done is something which was concave. Now you have put a sheet over it, and you have converted this into an osteofibrous tunnel. Now imagine that this carpal tunnel is a table whose up is down. So now you see these bones. Now one leg of that table is your pisiform. This is the medial side, and this one is your scaphoid. Then on the back, if you see, it is your hamate, and that is your trapezium. How can you remember what should come after the pisiform is? Most of us, we are anesthesiologists, and even though we are not, we always talk about pH, right? When we want to look at the pH of the blood or whatever, if it is metabolic acidosis, go order and pH. So remember it like that. So after pisiform, you should have your hamate. And after your scaphoid, we always say sit. So you can remember it like that. It is trapezium. So now pisiform and the scaphoid, they form the proximal boundary of they are like two persons who are standing, and they are forming the proximal carpal tunnel. And when you go further, you have your hamate, you have your trapezium, they form the distal carpal tunnel. Distal carpal tunnel is advanced level ultrasound. We will be talking only about the proximal carpal tunnel today. So now, again, I'm repeating, proximal carpal tunnel is an osteofibrous tunnel whose front two pillars, they are formed by two bones. What you need to remember, on the medial side, it is the pisiform. On the lateral side, it is the scaphoid. Now, on the top of this, you have your flexor retinaculum. So now this flexor retinaculum will be converting it into a tunnel shape. Let us see what all we have in that. If you are looking at this tunnel, look at this image. So you will be able to understand it nicely. Everything, all are tendons. Now tendons, they are subjected to anisotropy. So tendons in the short axis will be hyperechoic. And I always say, like when we talked about the Achilles tendon, that when we are looking at the tendon in the short axis, the tendon will be just like in hyperechoic dots, as if you are looking at the bristles of your brush. So all these tendons, they will be looking hyperechoic dots like thing. And if you tilt your probe, if you toggle your probe, you can just change the way you are looking at them. And on the top of this, you're going to have your median nerve. And if this median nerve is getting compressed inside this osteofibrous tunnel, we call it as carpal tunnel syndrome. So let us see what are what happens in carpal tunnel syndrome. Before going into that, about any nerve, what exactly you should know is what is the force of that nerve and what that nerve supplies. Suppose I'm talking about the carpal tunnel, I should know what exactly is the innervation of this nerve once it is going through this tunnel. It's like, there are two states and you have a tunnel. So you should know where exactly one boundary is ending and the other one is starting, and what all we have in that state. So that is very, very important. This road leads to what destination? In the same way, this nerve, about this median nerve, what you need to remember, two things, only two things you remember: carpal tunnel is over. This median nerve, I'm not talking about the proximal course. This median nerve, once before it enters the carpal tunnel, what you need to remember, approximately 5 centimeter proximal to the carpal tunnel. When I say carpal tunnel, proximal carpal tunnel means I'm talking about the carpal tunnel at the level of scaphoid and pisiform. So from, if just 5 centimeter from that pillar, if you go up, it gives off a branch, which is known as palmar cutaneous branch. And this branch is responsible for the sensation over your thenar aspect. Means if my nerve is involved in the carpal tunnel, the sensations over the thenar aspect, they should be intact. This is how you distinguish between a median nerve entrapment neuropathy at the wrist or it is proximal. So this is one distinguishing feature which every one of you should know. So the sensation over the thenar aspect is supplied by the palmar cutaneous branch of the median nerve, which is given off approximately 5 centimeter above the wrist. Now, once this nerve, it enters the carpal tunnel, it divides into two branches. One is your recurrent motor that is responsible for supplying the thenar muscles, and then it supplies the sensory aspect to our 3.5 digits. So this is what you need to remember. So supposedly a person has got any problem with the median nerve at the wrist. What are you going to look for? You will be looking for the sensation in the 3.5 fingers, and then you will be looking at the innervation of this muscles which are there on the thenar aspect. And just to remember that these muscles are the one, they will be doing the abduction, flexion, and they will be bringing this, helping us to just approximate the thumb with the little finger. If you remember these three things, it's more than sufficient. So let's have just revise what I have taught you. So this part will be supplied by the palmar cutaneous branch of the median nerve, which is given approximately at 5 centimeter above the wrist joint. In case of if you have an involvement of entrapment neuropathy, proximal entrapment neuropathy of the median nerve, this sensation will go off. But in the carpal tunnel, sensation over this will be those will be intact. Second thing, this recurrent motor, I have already told you. If you can remember the name of the muscles, that's fine. If you do not remember, you just remember that one is flexion, one is abduction, and then approximation of your thumb with your little finger. So these three muscles and two lumbricals. What is the function of the lumbricals? Do like this. So this is the function of the lumbricals. You have the flexion at your metacarpal joint and extension at your interphalangeal joint. So median nerve supplies two lumbricals, first and second. If you remember these functions, more than sufficient. Now, who all are the person who are going to get this carpal tunnel? A person who is obese, pregnancy, diabetes, hypothyroidism, and rheumatoid arthritis. How rheumatoid arthritis? All of them, they are going to cause the thickening of your flexor retinaculum. These are the certain things which you will be like, if a person who is very much obese, a pregnant female who comes to you, or patient says, I'm diabetic, I'm having hypothyroidism. Yes, I'm a rheumatoid arthritis patient. something like that. So they are all the risk factors for the carpal tunnel syndrome. These are the things which we can even make out with ultrasound. That's the reason this anatomical variance is very easy to see with ultrasound. But still, if you can remember, it's fine. Even if you do not remember, once you put the probe, you'll find something. If you know the normal thing and you're putting a probe and you're finding something abnormal, then obviously you'll be able to pick it up. So what are these? One is persistent median artery. We do not have median artery. We have radial artery and we have ulnar artery. Median artery is not there. But if along with the nerve, you are able to see some pulsation, I'll be showing you this. If you are able to see some pulsation, that is abnormal. And the nerve should be only one nerve. If you are able to see some two nerves, then this is also an abnormality. So other than this, if you have an SS2 ultrasound, if you're putting in ultrasound, you're looking at the median nerve and you are seeing something abnormal. So that is, they are the secondary causes for the carpal tunnel syndrome. And this is how I was talking about. You can have even the ganglionic cyst. This is how the persistent median artery will look like, bifid median nerve. So these are the things which you can just pick up with your ultrasound. You can have the tenosynovitis of the flexor tendon. So when I'll be showing you, I'll be telling you, I'll be showing you all this, the normal variant. So just remember the normal variant so that if you have any problem, you will be able to pick the abnormal thing very nicely. How will be the presentation? She will be a middle-aged female. What she will be complaining of, she'll come to you and she'll say, doctor, in the night when I'm sleeping, this will be the first symptom. In the night when I'm sleeping, I'm having some sensation in my, palm. And when I'm just trying to shake it off, that sensation will go off. This is how she'll be complaining of. This is going to be the first symptom. Later on, if your symptoms progresses, what all the normal thing, we should always in the history ask what exactly the normal things which aggravate the patient's pain. So you'll be saying, when I'm holding the newspaper, I'm finding it very difficult to hold. Now see how he is holding the newspaper. In order to hold the newspaper, we need to flex our wrist joint. Always remember, whenever either when we are flexing or when we are stretching the nerve. So these two components will be causing the pain. So here he is holding the newspaper, that will be causing the pain. Then holding the mobile, driving in the car, because that time also we need to, when we have to hold the steering. So that time also will be flexing. So whenever it's like the gist of the story is whenever he try to flex the wrist, that will be increasing the pain of the patient. Later on, if the carpal tunnel is progressing, holding even, something, because you need to abduct, you need to approximate your thumb with this. If I want to hold a glass, my hand should be like this. So all those things, if the atrophy has started progressing up, then holding the things will not be possible. Buttoning the shut will not be possible. Means the gripping thing when we are trying to make a fist. So that becomes difficult. What all are the tests? Penal sign. You tap on the median nerve exactly on the center of your, almost here, on the center of your wrist joint, and you just percuss it 2 fingers like this. You percuss it, I'll be showing you. So that will be causing a tingling sensation which will be radiating into the hand. Then this is the phalanx sign. This is reverse namaste sign. Again, we are flexing the median nerve, so that will be aggravating the pain. Then they say there is also something called as reverse phalanx test or the namaste. Here we are stretching. So this might be causing the pain, but the specificity of this seems to be better than the reverse, better than the phalanx test. So you can ask the patient to do a namaste or just the opposite of that, or you can just tap. So these are the 3 things which you need to do if you are suspecting it to be a carpal tunnel. This slide I will be sharing with you. Just cram this slide, because this is how you will be classifying the carpal tunnel into mild, moderate, and severe. Remember one thing, when it is a mild case, what will be the symptom? Symptoms will be only in the night, what I have already told you. And that time, everything, whatever you test, you do the tenal sign, and you go for a phalanx test, you do the test, everything will be perfectly all right, except the night pain, the night, those tingling sensation. And sometimes the first finger to be involved is your middle finger. Your long finger is the one. She will be saying only in one finger, I'm having this. So these will be present in mild cases. If you progress, if the disease is progressing towards the moderate side, now these symptoms, they will be throughout the day. And if it is severe, they are constantly present. So what is the only thing which is distinguishing between the moderate and the severe is the weakness and the atrophy. Weakness and atrophy will be in severe case, and they will not be there in the moderate case. So the gist of this slide, the take home message of this slide is, in the mild cases, patient will be having only night tingling sensation, something, some abnormal sensation. If it is a moderate, that will be present throughout the day. If it is severe, it is constantly present. Then what is the distinguishing feature between moderate and severe? Weakness and atrophy will be there in severe, but that will not be there in case of moderate. So this is what you need to remember. Regarding the test and all, everything, whatever is there, everything will be there in both the moderate and the severe cases. So we should know how to distinguish between them. History and physical examination, yes, that is the one that will be, on the basis of that, you will be forming the diagnosis. NCV is of a very diagnostic, I should say, the modality of choice, that is nerve conduction velocity, and you will see the decrease in the amplitudes and all in the nerve conduction velocity. Ultrasound is a very good modality, I should say, to find out the carpal tunnel syndrome. And what all we will see, that I'll just show you. So before going into the ultrasound, how exactly the things will look like, let us have a normal sonoanatomy first. And then I will be showing you the abnormal pictures so that you understand how things are. So let me stop sharing the screen, and I'll be just telling you the easiest way to just put a probe. And when you are putting a probe, you are just exactly over the carpal tunnel. So I'll be showing you that also. So let me start the virtual camera for you. I'm just pinning my video. Sir, somebody else has spotlighted the video. I'm not able to see the. Sir?
Hello?
I don't know, boss. I'm just pinning the video, but I'm not able to.
I have spotlighted your video only.
Okay, now it is fine. Fine, fine, fine. So first of all, whenever you want to examine anything under ultrasound, I always say position is very, very important. Until unless your position is proper, you will. I hope I am audible.
Yes, ma'am.
Okay, thank you.
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
So this elbow is extended, forearm is supinated, palm is facing up. This is just a rolled sheet which I have kept just beneath his wrist joint. He has got a normal curvature of the wrist. Otherwise, even if you do not keep this, you will be able to just put your probe and you will be able to get the carpal tunnel very nicely. Frequency is 13 megahertz. Depth, and you can see here that is the depth I have kept, approximately 2 centimeter. And my focus is this small white arrow. And because the median norm is a very superficial structure, so I have just kept it to 0.5 centimeter. What you need to do is, I will be just showing you in my this thing. If all of you can just do this, because that becomes easy, you will be learning it, and then if you go home and if you have an access to ultrasound, put your probe and just This is a radial styloid process. Okay, I'll do one thing. I'll show you this first so that you understand. I'll show you in my this face camera so that it is nicely visible. Fine. If we look at our wrist, if this side we see approximately somewhere here, all of you please do this so that you do not forget. From here, if you are palpating, this is a radial styloid process. You keep on palpating and then you will be able to see a bony thing. So that bony thing is your scaphoid tubercle. Now with this, you keep this index finger right there and you approximately open your fingers you wide apart so that your middle finger is over again a bony thing. So that becomes your pisiform. It is very easy. You palpate these two, and I always say when you are learning ultrasound in your initial days, please take help of your bones. They are really very good friends and they will never let you down. So you just palpate these two, and this is what I'll be doing. Now this is the thumb side and little finger side. So what he has got some abnormality. So it will be difficult for me, but don't worry, I'll show you. So you can palpate this side. Okay. And you just put your probe. Now once you have put your probe, what exactly you need to see, that's what I will show you. Let me get the best picture so that I can show you things well. Okay, I'll just show you the median now first because I told you he has got a little bit of curvature difficulty, but for me it is like because I know, but when you are learning, it is little difficult. Now what you need to see here is when we are putting the probe, just look at the structures and then I will be again showing you things. When I have put up the probe, one thing that I need to show you again, you will be able to see two rounded, two inverted U-shaped structure. Here will be the one and you will be able to see one here. So those two inverted U-shaped thing on, because this was the medial side where our aspect marker was, it was the lateral side. So we have already learned that on the lateral side, we will be looking at the scaphoid, and on the medial side, we will be looking at the pisiform. Now, on the top of the pisiform, you're going to have the flexor carpi ulnaris, and on the top of this, you're going to have flexor carpi radialis. If you want to remember, it's fine. If not, this forget it. What you need to see here is this thing. See this honeycomb structure, which is here. This is our median. And how to identify that? See, on the top of the median now, this hyperechoic line, something which is going like a tent, coming, and going here. So this is our flexor retinaculum. And one clue is this median now will be sitting on again. See, it's a mountain, hyperechoic thing. So this mountain which we are looking at is our lunate form. So this median now should be, you approximately just have an idea that there should be a bone, and on the top, on the center of the bone, you should be able to see some honeycomb appearance, and this is your median nerve. All these are tendons. I will be showing you how to distinguish between the median nerve and the tendon. Before that, let us know how to measure this, because that is also very important. When I'll be discussing the measurement, you should know. So how you are going to measure from the center to the center, And then again from this side, for the time being, just learn how to measure, because all these things is not there in my PPT, only the area is there. So remember how we have measured. We have measured from the center to the center, and then means we have measured it vertically and we have measured it horizontally. Now remember, it was 2 and 7.1. This much you remember, and then when I'll be showing you, I'll be telling you other things. Fine. So that was the median nerve. Now, if I want to go about doing an intervention of this nerve, how am I supposed to come? Now, again, you see, I have put the measure button for you to see that. From there, you will come and first, either you can inject here, that is beneath the nerve, and then again from there you will go back and you will be injecting above the nerve. Means one needle should be beneath the nerve and then on the top of the nerve. And what you will see? You will see that this hyperechoic thing which we are able to see, you will be seeing that this honeycomb appearance of this honeycomb appearance and this hyperechoic, they will be separating. Your injected will be going beneath the nerve and then on the top. When it is going beneath the nerve, the flexor tendons will be getting separated. The injected will be somewhere here in this plane. And when you are injecting above the nerve, your injected will be between your flexor reticulum and your median nerve. Now I will show you what all we should be seeing. So just see the live scanning now, because now you have understood the structures. So when I'm putting the probe, what U shape I was telling you, this is the U shape I was telling you. Now this is the lateral side, because how the probe I'm holding the probe in the short axis to the lower end of the radius and the ulna, and my aspect marker is towards the lateral side. So what I was telling you is
Excuse me, Miss. Is it better to increase gain, Miss?
Now is it visible properly? Actually, for me, it is too much of gain. Okay, now it is fine for you. Is it fine for you?
Yes, ma'am.
Because here it is almost 65% of gain. Now, are you able to see it?
Yes, ma'am. Thank you, ma'am.
Fine. But it is too bright. No worries. If you are comfortable with that, I'm fine. But I can just, okay, see. This is the bone. So this is the bone since it's on the lateral side. So this is our scaphoid. The same thing, we should be seeing it on the medial side. Now you see, on the medial side, again, what we are looking? We are looking again an inverted U-shaped structure. Let me shift my probe like this. So now this becomes our pisiform bone. You are able to see an artery over here, and this will be the ulnar nerve. How can you remember? I'll tell you again a trick to remember that. So you auntie, no girl will like calling herself as auntie, right? But here we will learn it like that. So this is artery, A, aunt. U is the ulnar nerve, and T will be your flexor carpi ulnaris tendon, which will be somewhere here. Let me shift my probe and show you. So this is the tendon. So how can you remember it? This is artery, this is nerve, ulnar nerve. This will be your flexor carpi ulnaris tendon. This is our median nerve, and we should always come from this side, not from the radial side, because somewhere on the top, somewhere here, it is not very nicely seen, but a black dot you will be able to see. So that will be this one. So this is our palmar-cutaneous branch of the median nerve, which we have already seen. So if you come from the radial side, you have the chances of damaging this nerve. And even if after you do an intervention, patient will be saying, doctor, you told me that my pain will go off, but now I'm not able to see any sensation over my thenar aspect. So you would have damaged this palmar-cutaneous branch. So it's always safe to come from the ulnar side rather than coming from the radial side. Now this is the median nerve. Again, we can make use of the anisotropic. See, these things which are here, they are changing their, if I am toggling my probe, toggling means I'm just trying to tilt my probe here, this side and that side, and see they are just changing their pattern. And this is still the same, but this they are just changing. So they are the flexor tendons, and that is how to distinguish between the tendons and the nerves, right? So that was the sonoanatomy. So again, anything you want to ask in the sonoanatomy, or I'll just go back to the anatomy part.
Ma'am, how should we know that there is a compression of median nerve?
I'm coming to the pathology. Okay, I thought you should learn the normal anatomy, and then now we are talking about the pathology. Okay, so you will understand. Don't worry. So here comes your pathology. So many, right? This is what I have told you already. I'll be sharing this slide so that you can again, revise what I have told you. Now let's come to the pathology. How you will say what now suddenly, like few minutes back, someone was asking. What we have seen is the nerve will have, what exactly is the basic class we have learned? How exactly the nerve will look like? The nerve will have the connective tissue covering. And this is for all the nerves, because I will not be taking this sonoanatomy part, like pathologies, how the nerve will look like if there is a pathology. This will be same for all the nerves I'll be taking today. So that's the reason I'm giving much importance to this part right now. Understand it, and if you do not understand, please ask me. I'll be repeating it again and again. What we have learned in our basic class, the normal anatomy of the nerve is it has got a honeycomb appearance. How that honeycomb, how we are able to see that it is the honeycomb appearance is the outermost layer is a connect. Then you have the fascicles, which will be covered by your epineurium. So again, that is a connective tissue covering. And then you have your fascicles. Fascicles, they are hypoechoic. So you have the surrounding, which is hyperechoic. Then your black fascicles. And on the top of the fascicles, you have a covering. So if I'm cutting it, it's like, so many wires which are covered up, and I have cut them. So that is how the honeycomb appearance will look like. Just see, this is a normal nerve, which we have already seen. But the nerve, the size of that nerve, that's the reason I taught you how to measure the size, because that also has got a very, very important role to play when we are saying it is a carpal tunnel syndrome. What happens is this nerve, if you know the normal size, it is always less than 10 millimeters square. So if the nerve, if you are scanning daily, okay, median nerve looks like that. Suddenly, one day you're finding the patient has come with all this complaint, you have put the probe and you have found that the nerve is like big, not the one you have been already daily you have been scanning and you're looking at the median nerve. It is not like that. So the uniformly hypoechoic pattern which we were able to see, that will be lost. It will be, instead of that honeycomb appearance, as you can see in the pathology slide, it will be more of a hypoechoic, means those hyperechoic coverings which you were looking at inside the nerve will no longer be there. It will be more of a blackish thing. That is the first thing. Second thing, if you are putting it in the long axis, what usually happens whenever there is an entrapment, if this is the nerve which is traveling, you have an entrapment here. So what will happen? You have a proximal dilatation of the nerve. And then within that entrapment, the nerve will be compressed and then it will become normal. So this is the normal pathology, which happens in all the nerves. Whenever you have an entrapment, again, I'm repeating, proximal dilatation of the nerve will be there. Inside the entrapment side, the nerve will be compressed, and then it becomes, if there is nothing, it will just come out. So when it is compressed there, it will be whole of this fascicles and all those, they will be just compressed. And beneath that, it will be just bulging. So this is what you are able to see here. So this sign we call in ultrasound as knot sign, and it will be there. If you look at the cut section from this, see, this is the nerve which is almost compressed. This is the proximal dilatation of the nerve. Now this is inside that entrapment side, and then the nerve continues. So this is how it will be there. First thing, there will be a loss of the fascicular pattern. The nerve will be looking more hypoechoic. Then if you're putting it in the longitudinal axis, there will be a proximal dilatation and then flattening of that nerve within the entrapment site. So these are the things which you should know. Now I have taught you to measure this area. What was the importance of learning that? You, like the lady I told you, she has come to you. She was complaining of only the night. Now, not the night pain. In fact, it is now throughout the day. Let's talk about the moderate thing. So you have put your probe, you could found everything. But what is more important is to measure this now. If you measure this now, how I have taught you. So this is the formula. Everybody should just ratify this, just cram it. This formula is very, very important. Pi A into B divided by 4. So this is the formula which all of you should know. And how to take this A? A was that the horizontal diameter which we have taken. What is B? B was the vertical diameter which we have taken. So pi divided by 4 A into B. This is how you will be calculating the area of the median nerve. Usually in a normal individual, it is less than 10 millimeter square. That is normal. But if it is more than 10 millimeter square, it is significant of carpal tunnel syndrome. But if patient has got atrophy and you have tried to measure the area, it comes out to be 15 millimeter square. That is suggestive of severe compression. Take help of our orthopedic friends. They are very good friends of us. So you can just send the patient to them, because we will not be the one who will be just taking care of this. You can just do any intervention if you find something between 10 to 12, something like that. Not more than 15, please do not touch the patient. Then what exactly you should do? Always in any entrapment, this is for everything. You stop the activities, ask the patient.
Sorry, ma'am. Sorry, ma'am.
Yes.
The formula is A times B divided.
Okay, now note it down. Everybody take a screenshot of this.
A times B divided by 4.
Yes,
correct,
pi.
ma'am?
This is pi. 22.7, 22 divided by 7, we used to say na 1.44 like that.
Oh, pi A times B. Okay, ma'am. Thank you, ma'am.
Okay. So we should be asking the patient to stop that activity. Supposedly the lady was sleeping like this in the night. Ask her, you give her some splinting so that the wrist is not flexing like that, and that if this flexion of the wrist is not compressing that nerve. And obviously the physical therapy, NSAIDs, all these things you can give it in the mild condition. Now, if it is a moderate to severe, I should say, then we can go about doing an intervention. How to do the intervention, I have already taught you. Now, let's see what all we can do. You can give, always remember, this is for, again, all the nerves. Do not give so much of volume, because what will happen if you are going to give lots and lots of volume, you will be just precipitating the compression, because already it's a tunnel, and your volume will be again, it's a vicious cycle. You will not be breaking the cycle, but you will be just continuing the vicious cycle. So limit your injected approximately to 2 to 3 ml, not more than that. Local with steroid you can give, but if you see the literature, the significant relief beyond 1 month is not there. So if you want to give, if you do not have an access to your ultrasound, to your PRP, yes, you can go about giving in local with steroid just to help the patient in just reducing the pain by just reducing the inflammation of the nerve. That is the one thing which you can do. Second thing, which is my favorite, is dextrose. 5% dextrose you can give, because this dextrose has got a very important role to play. There are receptors which we call it as TRPV1 receptor, and these are the receptors. They are the one, they will be triggering the nociceptive sensations. So if you are giving dextrose, dextrose causes the inhibition of these receptors. So we are not just sending the inflammatory, that stimuli, the action potential which is generated. So we are just breaking it there. That's how the dextrose help. So if you want to go for the hydrodissection of the nerve, you can use local with steroid, one thing. Second thing, you can use 5% dextrose. Dextrose has got an additional role, which I have already told. PRP is very, very good. And PRP, how it helps the nerve. PRP helps as, these are the two articles, very nice articles. I'll be sending you today night as study materials. Go through these articles. They are superb articles on PRP. So what they have said that this PRP helps us in remyelination, axon regeneration, and angiogenesis of the injured nerves. In short and sweet manner, it helps in healing the nerve. So PRP and dextrose has got an additional roles other than just reducing the inflammation and all which is there with steroid. These two have got two additional features. And sometimes what you can do if you have two cases, how sometimes I do. If I have two cases, instead of throwing the platelet poor plasma, sometimes I use that also for hydrodissection. There are studies they have proved that it contains that alpha 2 macroglobulin. That also is very helpful in the repair of the nerve. So if you have two interventions planned together, instead of throwing that, you have very little access to the PRP, so that also you can use. And then finally the surgical surgery. So I hope carpal tunnel is over, and I will be just revising the silent features because rest all it will be the same. So I will not be insisting more on the treatment. It will be same for all the nerve entrapment. So let us revise carpal tunnel once again. Carpal tunnel, when we say proximal carpal tunnel, it is from your scaphoid and pisiform. That is your proximal carpal tunnel. And then if there is an entrapment, what happens in carpal tunnel? You have the entrapment of the median nerve. Usually it is the obesity, hypothyroidism, diabetes, pregnancy, rheumatoid arthritis, most commonly associated with the carpal tunnel syndrome. Risk factors for the carpal tunnel syndrome. Other than that, you have secondary causes, flexor, the tenosynovitis. You have seen the flexor tendon over there. So if there is a tenosynovitis, obviously the patient is going to have. Then I have talked about the median artery and the bifid median nerve. These things you will be able to see with the ultrasound. What we have seen in the ultrasound, there was only one nerve. But instead of that, if you are able to see two nerves, yes, that is a problem. Now, coming to the clinical features, she will be a woman, middle age, and she'll come with you with the night pain starting usually in this middle finger. And yes, you can have in 3.5 digit, any digit, but usually they say it starts with the index finger, and that is the mild case. In the moderate case, what will happen? You will not be having the weakness and atrophy, and that will be there in the severe case. Severe case, orthopedic friends, they are going to help us. And if it is a mild case, just give her conservative things, give her a splint, ask her to avoid the activities which aggravate her pain. If it is moderate to severe, go for an intervention. For an intervention, you can use local with steroid, you can use PR, use dextrose, and even you can use the platelet poor plasma. So that was all about the carpal tunnel. So let's talk about the cubital tunnel. When we say cubital tunnel, this is the entrapment of the ulnar nerve. In the elbow class, I think you have just understood where exactly the nerves are located. I'll be showing you again just briefly. On the medial side is your median nerve and median nerve, and just little if you go posterior, then you have your ulnar nerve, and on the lateral side you have your radial nerve. So this is how is the arrangement of the nerves around the elbow. Carpal tunnel is the most important entrapment neuropathy, and if you go to the second entrapment neuropathy is cubital tunnel. Again, when I say tunnel, they are all osteofibrous canals, and how they are formed, that is more important for us to understand. Now look at this slide. Here you have your medial epicondyle. On the posterior aspect, you have your olecranon process. Again, two bones, two pillars. Always remember, this is how I have remembered, that you have two pillars, and on the top of the pillars, you should have something to convert that into a tunnel. So you have your medial epicondyle, then on other bone which is there is you have your olecranon process. Now this medial epicondyle and the olecranon process, they will be connecting, they are connected by one ligament. Here, this name of this ligament is Osborn's ligament. Some book says it as cubital retinaculum. If you go deeper, if you go little caudal, what you will see, you are having a flexor carpi ulnaris. It has got an humeral head and an ulnar head. So this humeral head is from medial epicondyle. Medial epicondyle is a part of the humerus. That's why this becomes the humeral head. Ulnaris is from olecranon process. Olecranon process is a part of ulna. That's why this becomes the ulnar head. Now, in between these two heads are connected by an aponeurosis. So what happens, this ulnar nerve, after traversing beneath this Osborn ligament, it enters into just deep to the FCU aponeurosis. Some books also call it as arcuate ligament, but I prefer to call it as FU aponeurosis, and that is also there in all the books. So now then it enters just beneath the flexor carpi ulnaris aponeurosis. So this whole area, this ulnar nerve is subjected to entrapment because now it is a tunnel. Again, just look at this boundary once again. Medial side, medial epicondyle. Here you have laterally, you have the olecranon process. They are connected by the Osborn ligament. And then you have, if you go little distally, then you have your both the ulnaris and the humeral head of your FCU. Now, this floor is formed by the, you must have learned again in the elbow that the medial collateral ligament has got three bands. You have an anterior band, posterior band, and a transverse band. And we will not be able to see with ultrasound. We will be able to see the medial band and the posterior band. So posterior band, yes, it is the posterior band which forms the floor of the cubital tunnel, and we will be able to see some portion of it when we are just putting the probe and looking at the ulnar nerve. Now, what happens in this cubital tunnel? All of you can just put two of your fingers again, one on the medial epicondyle, one on the olecranon process, and just keep it when your elbow is extended. So this is the extension of the elbow and this is the flexion of the elbow. So just keep two of your fingers, one on the medial epicondyle, other on the olecranon process. First, you keep it in the extended thing and then you flex. So when you will flex, you will see that your two fingers are moving apart. So means when we are just flexing the elbow, the distance between our medial epicondyle process, it increases. And what happens? So this FCU aponeurosis, what we have learned. Somebody is unmuted. Please mute yourself if you do not have any question to ask. Now this aponeurosis, it tightens. So that way you are going to have the compression of this nerve. What all are the things that can do that? Okay, before that, let us learn what all this ulnar nerve it supplies. As we have seen, it passes through the two your FCU. So obviously this is going to supply the flexor carpi ulnaris muscle, and this muscle is the one which will be causing the flexion of our wrist joint. So if there is some problem, because this causes the ulnar side flexion and the ulnar deviation. So what will happen? The wrist will be going towards the radial side if my FCU is not working. Why? Because this radialis will be working very nicely. So muscle, always remember, it is like a seesaw. Both of them, they are maintaining each other. If one is damaged, think that the other thing will be going towards that side. If this is damaged, it will go towards this side. So just have this picture in your mind that on the radialis side, you have the radialis. Ulnar side, you have the ulnaris. If your ulnaris is not functioning, where wrist will go? Because now this is useless. So it will be going towards the radial side. Now this, I'm sorry, this ulnar nerve will be again supplying the ulnar head of your flexor digitorum profundus. So these are the two muscles, and all third and fourth lumbricals. We have learned first and second, they are supplied by medial nerve. Third and fourth, they are supplied by ulnar nerve. Both the palmar and the dorsal interosseous. Now, how can you remember? This is, they causes the adduction and abduction. So if you want to test for it, you should be testing the adduction and with the abduction. I'll be coming to that now. Then thenar we have learned, it was all by median nerve. So hypothenar is by ulnar. This is how you should remember. This side, what we have learned, flexion, abduction, and just bringing the thumb. Same thing will be there for the hypothenar side also. Other than that, one additional thing which you should know, is your adductor pollicis that is supplied by your ulnar nerve. If you do not remember all this, again, nothing to worry about. I'll just tell you the test. Just remember those tests because you need to perform all those tests if you're thinking of a cubital tunnel syndrome. So this ulnar nerve, if you look at the sensory supply, it supplies 1.5 fingers of our on the palmar side. Now, what is important here is 3.5 is by median, 1.5 is by ulnar. Who all are more prone for developing this tunnel syndrome? So before that, let us revise the motor supply. 1 flexor carpi ulnaris and the medial half of your flexor digitorum prophatus. Then because it is on the ulnar side. So you just remember, if you do not remember the name of the muscles, forget. You just remember this is something which is on this hypothenar side, that one. Then because it is on this side, so 3rd and 4th lumbricals, and we have already learned the function of the lumbricals. Think of lumbricals like an L only. So you will never forget. You just make an L and think that this is the function of the lumbricals. So lumbricals L, extension of your interphalangeal joint and flexion of your metacarpal joint. It supplies 3rd and 4th lumbricals, and then the interosseous are exclusively supplied by ulnar nerve. So ulnar nerve, we have seen that it has got lots of motor innervation as compared to the median nerve. Now, who all are prone to develop this cubital tunnel syndrome? A person, I have told you, like when we are just flexing, so when we are flexing, that is the time when we are just compressing this ulnar nerve. So if you are sitting on your table, like how this person is sitting, leaning on the elbow, and then this is the position I used to sleep, but now I have changed it. So do not sleep like that, with the like this. So if you are going to sleep like the baby, how the baby is inside the womb. So if you're going to sleep like that, you will be flexing your elbow. If you're flexing your elbow, then you are just increasing the compression on the ulnar nerve. Then these are the other things: blunt trauma, tumors, diabetes, even in accessory and corneous muscle, lipoma, means anything which is there in that tunnel. Just think of what all can be there. If it is from the subcutaneous tissue, you can have the lipomas. Yes, they can compress. Actually, there is no muscle. We have seen that there is no muscle inside that cubital tunnel. So suddenly, if you are able to see some muscle, so then obviously it is going to cause cubital tunnel, and that accessory muscle will be only and only encomius. So all these things you will be able to see with ultrasound, but knowing that, you should know the normal things, so that whenever you're looking something abnormal, okay, if you can just think, okay, this might be the cause for it. But these are the 2 basic things. A person who is always sitting on the computer might come to you. I have seen, yes, madam, I'm having pain which is radiating from here up to the 1.5 finger. So flexion is very, very important. So think of cubital tunnel, think of the flexion elbow. When you are thinking of the carpal tunnel, think of the flexion of the wrist. Then this, I have already spoken to you about the pathology. This Guyon's canal is not there. Actually, I've just forgotten to remove this. Fine. What exactly are the symptoms? This I have already discussed with you, that the patient will be having the pain, which will be almost from the medial elbow radiating down to the fingers. Now, this is what you should know. We have to do the flexion of the elbow, and we should flex the elbow, and then you just extend your extensor compartment. You just stretch your extensor compartment. So the patient will be, if you'll just ask the patient to do like this and hold for a second, he'll be saying, no, I cannot do, it's paining a lot for me. I have started developing those tingling sensation. This is a very quick test which you can do it in your OPD. So first, you just remember this position. So we are just stretching the extensor compartment and flexing the elbow. One test, do remember this test. Second thing, obviously the tenal sign, because it just passes beneath a groove which is present just behind your medial epicondyle. Then we have talked that it supplies your palmar and dorsal interosseous. So if there is a weakness, what is the function of your palmar interosseous? Remember that if you want to bless someone, you are going to bless like this. So what is this? This is adduction. So palmar interosseous function is adduction and dorsal is abduction. I always remember one so that the opposite, I always just correlate. When you will be having the problem with this, if you just give a card to the patient and just ask him to hold it, this is a paper, you give this paper to the patient and you ask him to hold like this, patient will not be able to do so. So that is for the palmar. Again, for the dorsal, yes, you ask the patient to move this apart, he will not be able to do. Then what usually sometimes he says that when I'm trying to put my hand inside the pocket, my little finger doesn't come inside. It's always abducted. It's always out. So that is also a clue to you. Then claw hand, it is because the lumbricals, they are not functioning. But since it supplies only the third and fourth, so you're going to have the problem with this. See now how it is. The metacarpals, they are extended and the interphalangeal joints, they are flexed. So if you know the normal function, abnormal, picking up the abnormal is very, very, very easy. Then is the Froment sign. What is this? You ask the patient to hold this. I told you to remember one muscle, that was adductor pollicis. Now this is the basis of learning that muscle. If your adduction, ask the patient to hold it, hold a paper with the thumb. You give a paper and ask him to hold it with the thumb like this, what it is shown. What will happen? Because your adductor is not working. So what this patient will do, he will take use of the flexor pollicis longus. And flexor pollicis longus is supplied by your anterior interosseous nerve. So he'll be taking use of that muscle to hold that paper. So the thumb will not be like this. It will be like this, what is shown here, the arrow which I have pointed. So the other one is the normal and this is the abnormal. Fine. So again, let us revise the cubital tunnel. Cubital tunnel, how will be the presentation of the pain? Pain will be on the medial side. That will be radiating to almost 1.5 fingers. Then you're going to have the weakness of your flexor carpi ulnaris. So what will happen if ulnaris is not working? You will be having the deviation of your wrist towards the radial side. What we have learned, it supplies the hypothenar muscles. So you're going to have the weakness and atrophy of the muscles over the hypothenar area. Lumbricals, we have seen that it supplies the third and fourth lumbricals and their function is this L. So this L will not be there. It will be just the opposite of L. Interosseous, we have learned when we want to bless someone, our palm should be like this. So palmar interosseous function is adduction and the dorsal one is abduction. So patient will not be able, neither he will be able to adduct nor abduct. Then comes your sensory, which I have already shown. Again, NCV and all those things you can order. So I will be showing you now the ulnar nerve. Let's see, and then we will come to the pathology. Mali late Joe. See, when you want to examine the cubital tunnel, it is always better make the patient lie down so you get a space. So you can just get a space to examine the medial epicondyle, right? I always do like that. And you can just keep the, and also friends, they usually keep that, a table. Somebody is unmuted, please mute yourself. I hope it is visible now to you. So see, he is lying down in the supine position because I want to go for the dynamic examination of the ulnar nerve also. Either you will do it in the supine position. Leave me sitting. You want to ask someone? You want to ask me something? Someone is unmuted. Sir, please mute. There is someone who is unmuted. I think it is Dr. Dipinder Kaur. You are unmuted. Please mute yourself.
I have muted her. I muted.
So ulnar now, I always examine it like you. I keep a table over here, but because we have to show, so I'm not keeping it. Patient is lying down in the supine posture. This is the arm of the patient. Now the forearm, see it is again. Okay, let me show you like that so that you'll be able to see. This forearm is supinated. I want to just see the medial epicondyle, which is here, and the olecranon process, which is here. What I'm going to do is I will be keeping my probe in such a way that it is bridging the medial epicondyle and the olecranon process. So let me get the. Now see, what am I? Okay, let me explain the probe position first. Position I have explained you, and I'm just pushing it towards the lateral side, just giving a valgus stress to the elbow so that the medial epicondyle is nicely visible. Probe is again in the short axis to the lower end of the humerus. Aspect marker is towards me now. How am I keeping it? I'm just holding the probe and keeping it over the.
Madam, sound is not clear, please.
My voice is not clear.
Now clear, madam.
Is it okay now?
Yes, madam.
Actually, I'm having a bad throat. I cannot increase the volume today. If you are not able to hear, I can just do one thing. I can push my.
Actually, you are nicely audible. I think there might be the internet problem of that particular person, but otherwise you are nicely visible. No need of taking more load on your voice.
So now you see what I will just, you see these two hyperechoic bones, and then I will be explaining you about the ulnar nerve, where exactly we are going to see this. Malik, please start now. Please start now. Now see here, on one side, there was a bone here, and it was casting an it was casting an acoustic shadow. So this is bone. Again, I will be showing you. So okay. Again, I will be just showing you. So this side, because this was the aspect marker side, right? So aspect marker, I have kept it over the medial epicondyle. So this is our medial epicondyle, and this one is our olecranon process. This is the posterior bundle of our medial collateral ligament. You can see the hyperechoic fibrillar pattern over there, right? Now here you are able to see something like this. Always remember one thing about the ulnar nerve, peculiarity of the ulnar nerve, that in the cubital tunnel, it looks very dirty. And it is like this only. And if there is an enlargement, the picture I will be showing you, that time you will be able to find out that how big it will become if there is a compression of the ulnar nerve. So this side, we have the medial epicondyle, and this side, we have the olecranon process, posterior bundle of the medial collateral ligament, and this is the ulnar nerve, which we should be looking at. What you need to do, again, the same thing, always. Now, if there are some, the book says that the measurement of this, it should be around, if it is more than 7.9 millimeters square, that is suggestive of any pathology of this. But what I usually do is, I measure it. I suppose a patient has come to me only with one side. You compare it with the normal side. So that is the best way. And again, the same way you will be just measuring it. How I have told you, we will be taking the Just give me a second. I'm coming out of the measurement. So we will be just measuring it in the short axis. That is, we will be measuring it vertically as well as horizontally. So this is where you need to measure it very closer to the medial epicondyle. So this was all about the ulnar nerve. Quickly, I'll go through the radial nerve. Let's see the pathology. Let me change the camera. Anything you want to ask here in that? Anything you want to ask there? Like ask about this, then because I need to change the position. So if you want me to show anything about the cubital tunnel, I can show you. Otherwise, I'll be just changing the position.
Kanchan,
Ma'am,
would you like to
this,
take
this,
some break?
this,
Your voice is
Sir,
looking,
I'll just finish the radial nerve and then
you can understand that you are very much tired and your voice is reflecting.
ma'am, the test again, ma'am, the test, the flex,
Oh, yes.
elbow.
Okay. I will just show you. Thank you for reminding me. I'll just show you.
Okay. Okay, ma'am.
Okay. Am I audible?
Yes, you are
Yes,
audible.
ma'am.
Yes, ma'am.
Now see, what we have learned is, remember one thing, that this nerve, it should always stay closer to the medial epicondyle, even if I'm flexing. If this nerve is not here, when I'm flexing, this nerve is going here. Okay, this should always stick closer to the medial epicondyle. If it is not sticking here itself and I'm flexing, but where it is going, it is coming just anterior here. So that is abnormal. This we call it as subluxation. And if instead of coming here, it is going almost here, this is called as dislocation. So again, in the dislocation, we are going to take help of our orthopedic friend. But subluxation, yes, we can ask the patient to avoid activities. And this, whenever you are looking at the ulnar nerve, do not forget to do this dynamic examination. It is very, very important. So let's see how to do it. Again, the same position of the patient and all. And the pro position is also same. The aspect marker is towards the, aspect marker is on the medial epicondyle. So what you are seeing laterally is the medial epicondyle. I'll just try to get the best picture so that from there we can just start the section. So now this elbow is almost extended. Now you see, I'll be flexing it. Just look at that now. When I'm flexing, flexion. Okay? It is still there, closer to the medial epicondyle. So neither it has subluxated nor it has dislocated. So that is very important, because if you have cubital tunnel syndrome, you are expecting, but it's a dislocated nerve and you are just trying to do an intervention, believe me, the patient will come back to you saying that what you have done, my pain is still there, because we are not the one who should be treating the dislocation part. This orthopedic, our friends, they will be just repositioning the nerve. So we can take help of them that time. So let us just look at the pathologies. I'll just quickly finish the radial now, because lot is there for the lower limb also. Now you have seen how exactly the nerve was looking. Now see, if there is a problem with the nerve, now see how big it looks like. So now if you know the normal nerve, that it looks like within the nerve, we were able to see some hyperechoic thing. But if it's a pathological nerve, you will not be able to see those white things inside the nerve. Rather, it will be a fully black thing, which is shown here in this slide. So that is how the pathological nerve will look like. Again, the compression, again, the conservative treatment remains the same. And if supposedly you have done an intervention also. Intervention also, again, the same thing. You can use a local with a steroid. Somebody is again unmuted. I would really am requesting you to mute yourself if you do not have any question to ask. Sometimes it distracts the class. I just lost the continuity. Okay. So thank you who has muted themselves. And initial stage, yes, give some, the what I have told you, rest, ask the patient not to go for the activities which aggravate the patient, which aggravate the pain, and give some NSAIDs. And if with that patient is not improving, go for an intervention. But when to send the patient for surgery is like, if irrespective of everything, 6 to 12 weeks you should wait. That is the normal natural history of that nerve to heal. And if after that also pain is persisting, then we need to go for a repositioning of the nerve. This is how you give a block to this nerve. Again, I'll be sharing you this slide so you can just go through it. Coming to the radial tunnel. Radial tunnel is very recent upcoming thing in pain. So you should know what exactly it is. When we say radial tunnel, you would have learned in your elbow class these 3 muscles. I always teach that, remember, 3 muscles, 1 tendon, 2 nerves, and 1 artery. So 3 muscles in the elbow, you have the brachialis, pronator teres, and the brachioradialis. In between the brachialis and the brachioradialis, you have your radial nerve. And in between these two, you have your median nerve. Now, what happens is, what exactly is radial tunnel? Radial tunnel, we say it's like, again, it's a tunnel. And how this tunnel is being formed. So look at this slide and you will be able to understand it nicely. We say it is from this is what? The rounded thing. Again, going back to our elbow days, the rounded thing on the distal articular surface, which you see is your capitulum, and the wing-like thing is your trochlea. So we are here. So this, from this to the proximal edge of the supinator, that is the extent. Means this is something like a tunnel thing. Now, how this thing will be converting into a tunnel? So this is the roadmap, that from your radiocapitular joint up to the proximal edge, we call it as radial tunnel. What will be the floor? Floor will be the capsule which will be covering this joint. What we have on the lateral side, we have the brachioradialis. This is the lateral side. From tunnel is going like this. So on the lateral side, you have your ECRL, that is extensor carpi radialis longus, brevis, and brachioradialis, which forms the mobile VAD. We call it as mobile VAD. And on the medial side, you have your biceps tendon and your brachialis muscle. So now everything is surrounded from all the sides, and this area now becomes a tunnel. So if you have the entrapment of the deep branch of the radial nerve, we call it as radial tunnel syndrome. Why I'm not calling it as PIN, I will come to it in a while. So when the radial nerve, it divides into a superficial branch and a deep branch. The deep branch is the one which passes between the 2 heads of the supinator muscle. And where it is entering the 2 heads of the supinator, on this, on the top, you have the arcade of forceps. This is a fibrous ridge which is there. And if this ridge becomes thickened, you remember it like that. It's a normal thing, but suddenly it has become very thick. So if it has become very thick, so that could be the reason for the entrapment of this deep branch. Now, radial nerve, superficial branch, and the deep branch. Now, this deep branch is the one which is passing between the 2 heads. Once it comes out of the supinator muscle, means it is just traveling beneath the, inside the 2 heads, and now it is coming out of it. So when it is coming out, posterior interosseous nerve. But if you see and this posterior interosseous nerve is the one which will be supplying all the muscles of the posterior compartment. Now, what is the controversy here is, in fact, there is a variable definition of the radial tunnel itself. Some says the radial tunnel stops distally. It is not only at the proximal edge. Some says this hole itself is not a radial tunnel. So there are lots and lots of controversy, even with the nomenclature, even with the extent of this radial tunnel. Second thing is, some says that this should be called as PIN and not the deep branch, not the entrapment of the deep branch of radial nerve or radial tunnel syndrome. There should be a separate name for it. But if you see why we are calling it as an entrapment of the deep branch of the radial nerve is, if you see the PIN, that is posterior interosseous nerve, it is the nerve which supplies the extensor muscles of the posterior compartment, and they are all causing the extension of the wrist and the fingers. Now, what happens if you have a pathology of your extensors? If you have a pathology of your posterior interosseous nerve, then the extension will not be there, right? That is the one thing. Second thing means, other way, you will be having the weakness of the muscles which will be supplied by that nerve. But in radial tunnel, what they have found is that it is only the pain. There is no weakness. You order an NCV is perfectly normal. You order an MRI, that is also perfectly normal. So that it is just a friction which is happening there, and that is irritating the nerve, and the nerve is becoming edematous and it is getting entrapped. So that is how there are two schools of thoughts. One says it is something different. It is only the PIN because the deep branch enters the supinator and then becomes the PIN. So it is now the whole PIN, not the deep branch. But some says it is just the entrapment of deep branch, and we should call it as radial tunnel syndrome, because whatever should be there in the nerve pathology, like you should have the weakness of the muscle, all those things will not be there. It will be only a pain, and where exactly that pain will be. That pain will be approximately 3 to 5 centimeter finger breadths distal to the lateral epicondyle. So only the tenderness will be there. And if you just do the stretching, because if I'm doing like this, I'm just stretching the extensor compartment, I'm just stretching this nerve. So that will be the provocative test. Patient will be complaining of pain exactly in that area. And because this branch, it supplies the supinator muscle. So if you test the supination, so that will be painful. And this was okay. Then if you go about going for an electrophysiology study, as I have said, nothing, nerve, you will see perfectly normal. MRI is also again normal in radial tunnel syndrome. So in ultrasound, how you examine this nerve, I will be showing you. And if there is a pathology of this nerve, then instead of looking at this black dot as a small dot, this will become like this. So I'll be showing you this. So remember, the gist of the story is, whenever you are having a radial tunnel syndrome, it will be painful, but posterior interosseous nerve syndrome will be painless. Second thing, you have fingers and thumb drop, means how it is shown in this picture. Patient will typically come to you like this. You try to extend, again it will be like this. So this we call it as fingers and thumb drop, because the extensors, they are supplied by PIN. PIN is not working. Then you have the drift of the hand in radial direction, which will not be there in all these features, will not be there in radial tunnel. That's why I'm telling you how to distinguish between these two features, and that is very important. So you will be having the drifting. When you will ask the patient to extend, the hand will drift in the radial direction. Why? Because extensor carpi radialis longus, that branch to that muscle will be supplied from the radial nerve itself. So that is active. Ulnaris is not working. What did I say? Remember the seesaw. Ulnaris is supplied by your PIN, but radialis is supplied by from the main branch. Now we are having an entrapment of something, you remember, terminal part. So the main part is functioning very well. It is only the terminal part which is not functioning. So that's the reason patient will be having the drift of the hand in the radial direction. NCV, yes, you will be able to see the decrease in the latency, all those things which will be there for an entrapment of nerve will be there if the PIN is involved. MRI, you will see the muscle atrophy, you will see the denervation. Everything just will not be there in radial tunnel syndrome. That's why there are two school of thoughts. I follow the radial tunnel syndrome. I do not call it as PIN if I do not see the symptoms. And PIN will mostly be because of ganglionic cyst impinging on the posterior interosseous nerve or a lipoma. Means space occupying lesion causing the compression of this nerve is more common. So let's have a look, and I'll just show you how exactly to find out the PIN by a very easy method. Mali. Again, in order to examine the posterior, examine the deep branch of the radial nerve, what you need to do is elbow is extended, forearm is supinated, and the palm facing up. This is the probe. Probe is in short axis to the distal end of the humerus. First thing, I hope all of you know this home page, which I usually call for our, elbow. You would have learned this, that this is the home page. Home page means this is the distal articular. Okay, let me switch on the arrow. I'm just increasing the depth so that you will be able to see it nicely. This is the distal articulating surface of the humerus. This rounded portion is our capitulum, and if you go to this side, this is our trochlea. This is an oblique facial plane, which is between, this is the brachialis. Brachialis will always be like a pyramid, and this is your brachiobrachialis. Now, in between these two, you are able to see two dots. Radial nerve will always be like two black dots. What you need to do not start from there. This is my own technique, and I found it very useful. And I hope all of you will also be benefited by this technique of mine. I do not start examining the deep branch from there. What I do is I put my probe in short axis to the radius, and what I do is I try to look for the two heads of the supinator. So let me just try to find out, and then I will tell you how exactly to go about looking for the deep branch. So what you need to do is, this is the probe. Probe is in short axis. Aspect marker is towards the lateral side, and this is the medial. You put your probe over. Okay, let me increase the depth so that it is nicely to go. Now you will be putting your probe over the radius, and the radius should be in this short axis. Look for something like this. One here, one here. In between these two, there should be one black dot. Again, you put approximately, I think, 3 centimeters beneath. So you are exactly, you will be over this structure where you will be able to see the two heads. Means two muscles should be there, and in between these two muscles, there should be a hyperechoic line. And in that hyperechoic line, look for this black dot. Okay, so this black dot, now we know that this is the supinator, superficial head, and the deep head. Now you trace it up. So you see, I will be tracing it up. This is the black dot. This is the black dot. Now this is the arcade of Forsyth. This one, see, it is entering. This is what we have seen in the picture. So now you should be looking at this nerve here. It is now entering. So it has entered. Now again see. And if you will trace this black dot, we will be going back where we were. So if you have any doubt, you can just trace, you can just move your probe up and you can see. So this is much easier than, starting from there and going. Sometimes you will not be able to see. But in this volunteer, since you are able to see it very nicely, and do not get confused because you have another black dot which is pulsating also. So they are radial recurrent vessels. So if you are tracing it, this black dot, and this black dot should be entering between the two muscles. Now, once you have done that, if you are not still very happy, you don't know whether it is a radial nerve or whether it is something else, what you need to do is, let me bring it to the center. You just rotate your probe longitudinal axis, and then you look for this nerve. Now, this is the nerve in the longitudinal axis. between the two heads of the superior. Now it is looking very nice, beautiful now. See, you are able to see the two hyperechoic line, and in between that, this black area. If there is a problem, this hyperechoic thing will not be there. It will be more, it will be plumpy thing, which I will be showing. So this is how you look at the radial now. And I think I've shown you that. So let me just show you once again. We have seen a smaller black dot. So this was that small black. Okay, I have not shared the screen. So now this is that black dot which we have already seen. If there is an entrapment, this will no longer be this much. This will be like this. And we have seen a beautiful two hyperechoic lines are very thin hypoechoic area in them, in between those two hyperechoic line. And now if there is an entrapment, so that blackish area within those two hyperechoic line will be too much enlarged. And how to go about doing an intervention is what I'll be sharing. So you can just go through it, how to go about doing an intervention, and the injected remains the same. So that was all about the upper limb entrapment. It is really a very big topic. So that really, I hope all of you must have understood this topic, and these two, especially you should know carpal tunnel and the cubital tunnel. Do not miss if some person with this pathology comes to you. And then lower limb is left. So before that, I would just like to take a break of a few minutes. And I think in that meantime, you play Kahoot. I'll take a break.
So Kanchan, you explained very nicely, but even with your sore throat and common cold, you continue till 1.5 hours.
Show must go on. This is what I believe in.
So you still lower limb are left. So I'll be asking Debjyoti to start Kahoot.
Okay, sir. I'll just take a break for 5 minutes and we'll continue with the Kahoot, and then I'll take lower limb because it's a big topic. So I hope all of you can just have something to drink, and because lower limb is also very important. And all of you, if you are practicing anesthesiologist, all those nerves which I'll be showing you will be very useful.
So when are you going to finish today? 9?
I most probably lower limb, I'll just cover it very fast. I'll just show them the nerves.
Okay,
and,
fine.
Okay, so I'll finish it off within mostly 40 minutes. So you can continue with Kahoot, sir.
Yes. Debjyoti, can you start Kahoot?